Hi everyone. Today we are going to continue with the rest of the chapter 6, which is the bone and skeletal tissues. So let's talk about the bone development. The bone development starts with the ossification process. So ossification, the word osteogenesis refers to the bone formation. The os refers to the bone, the genesis refers to the beginning. So ossification or osteogenesis is the process of bone tissue formation. And the bone formation, the skeleton, begins in the second month of the development. And the postnatal bone growth occurs until the early adulthood, and after that the bone remodeling and repair is happening lifelong. The formation of the bone skeleton starts before the 8th while you're at the embryo. And the fetal skeleton is made up from fibrous membranes and hyaline cartilage. And the bony skeleton can be formed in two ways, either endochondral ossification or the intramembranous ossification. The bone forms by replacing hyaline cartilage in the endochondral ossification, and the bones are called cartilage bones because they replace this hyaline cartilage, or we call them as endochondral bones. And cartilage bones are found in most of the skeleton. If the bones formed from the fibrous membrane, then we call them as intramembranous ossification. And these bones are called membranous bones. Let's look at these two ossifications one at a time. In the endochondral ossification, it forms essentially in all bones inferior to the base of the skull, except the clavicle. And this begins late in the second month of the development. And it uses previously formed hyaline cartilage models. And it requires breakdown of hyaline cartilage prior to the ossification. In long bones, particularly, begins at the primary ossification center, which is you find in the shaft of those long bones. What will happen is, first, the blood vessels, they infiltrate the perichondrium, the outer surface of the cartilage, and first it converts into the periosteum. So the hyaline cartilage is covered by the perichondrium. The blood vessels, they come and invade it, and then due to this invasion, lots of nutritional changes happen. So the perichondrium now converted into the periosteum. And the underlying mesenchymal cells, specialized into the osteoblasts, bone-forming cells. With related to the endochondral ossification, 5 main steps is happening. The very first one would be the bone collar formation, and this is happening around the diaphysis of the cartilage model. And the next step would be the central cartilage in diaphysis. It starts to calcify the central portion of this diaphysis, and that will lead to development of some cavities into it. Next, then a periosteal bud is invading these cavities, and the periosteal bud is composed of blood vessels, nerves, red marrow, osteogenic cells, and osteoclasts. So if you remember, the osteoblasts are formed by the mesenchymal cells underneath the periosteum, but the osteoclasts, they are now coming into the bone. So the periosteal bud is the one which carries that, and the invasion of the periosteal bud leads to formation of the spongy bone. Later, the diaphysis, it starts to elongate as deposit and formed, deposit calciums, and the medullary cavity starts to form. So the secondary ossification centers then starts to appear in the epiphysis. I hope you remember the diaphysis, the epiphysis, and the metaphysis. So the ends are, we call them as the epiphysis. The shaft area is called as the diaphysis. So in the as the medullary cavity forms, then the diaphysis starts to elongate, and what will happen at the epiphysis, you would find the secondary ossification centers. And this is the secondary ossification centers appearance is happening closer to the birth. Then it starts to ossify. The hyaline cartilage would only find then at the outer surface of the epiphysis, where the articulation happening with the joint areas, or at the area of the metaphysis plate. And your book describes nicely each and every figure over here you've seen. So this is formation of the bone collar and forming the over here in the diaphysis, the invasion of the periosteal bud, the secondary ossification centers formation, and the ossification is happening at the epiphysis and leaving the metaphysis plate, which is the cartilage plate, and well as the articular cartilage area that would be at the ends of the epiphysis over here. The other type of bone formation would be the intramembranous ossification. They begins within the fibrous connective tissue membranes, and they are formed by the mesenchymal cells. So these intramembranous ossification can be seen in the cranial bones of the skull, which is the frontal bone, parietal bone, occipital bone, and the temporal bone, and the clavicular bones. Four major steps involved in this ossification. The first, the ossification centers are formed when the mesenchymal cells cluster and become osteoblast, and they started to secrete the osteoid, and eventually this osteoid starts to calcify. And the woven bone started to form when this osteoid laid down around the blood vessels. The woven bone is called as the network of trabeculae, and osteoid laid down around the blood vessels, resulting trabecular formation. The outer layer of this bone then starts to form the periosteum, and later the lamellar bone replaced the woven bone and then turned the red, and you would see the red marrow appearance. So here you would see some ossification centers. This is the fibrous tissue. Some ossification centers appear in the fibrous connective tissue, and they started to secrete the osteoid, and then the cells which gets trapped in between those osteoids, they start to form osteocytes, and then the trabecula is formed over here, and at the end you would find the marrow cavity, and the lamellar bone replaces the woven bone, and then it forms the periosteum towards the end. And you would see the red marrow appears in the middle of this figure. This is the intramembranous and the endochondral ossification you would see until birth or while you're at the embryonic stage, and the postnatal bones start to see the growth of the bones. So postnatally, the long bones, they started to grow lengthwise by the interstitial growth, and that will lead to making the bones long. And in the interstitial growth, It originates in different centers within a structure or an area, which is characteristic of a tissue formed of non-rigid materials. So that is why it's allowed to elongate the bone. In addition, bone can increase its thickness as well through the appositional growth, that is, forming new layers on the surface of a pre-existing layer. So you have to remember the interstitial growth make the bones elongated, make them long. The appositional growth, they make them bones increase in thickness. In addition, bones stop growing during the adolescence. So, however, some bones in your body, which is some facial bones, the jaw bones, or some nasal bones, they continue to grow slowly throughout the life. Growth in the length of the long bones is important for us to know as well. So, the interstitial growth requires the presence of epiphyseal cartilage in the epiphyseal plate. And this epiphyseal plate, it maintains some constant thickness throughout as it grows. So the rate of how it happens is the rate of cartilage growth on one side balanced by the bone replacement on the other, because if you remember, the cartilage is the first structure, and then it's going to be ossified and calcified and formed into like strong bones. So the cartilage plate, the epiphyseal plate that you find during the growth, it remains constant. And how it remains constant would be the cartilage also is going to be formed as it's going to be at the same pace as the bone, it's turned into bones. So we have to see the epiphyseal plate for a second. The epiphyseal plate, it consists of 5 zones: the resting zone, the proliferation zone, the hypertrophic zone, the calcification zone, and the ossification zone. So as you can see, the resting zone is much more closer to the epiphyseal side, and as it moves down, this is where the diaphysis area, so this is much more, the ossification zone is much more closer to the diaphysis. The resting zone is much more closer to the epiphysis area. And in here you would see the proliferation zone is where the cartilage cells undergo mitosis, it increases its number. And then in hypertrophic zone, these older cartilage cells, it starts to enlarge. Hypertrophy means enlargement, making its size bigger. So these cells, cartilage cells, going to be mitotic cartilage cells. And then later in the calcification zones, the matrix starts to calcify, the cartilage cells die, and then the matrix begins deteriorating, and blood vessels invade, and that forms cavities. And here you would see in the ossification zone, you see the new bones formation. So near the end of the adolescence, the chondroblast cells, they divide less often, and at that time the epiphyseal plate thins and it's replaced by bone. So epiphyseal plate closure happens when the epiphysis and diaphysis fuse together, and there's no more cartilage in between those epiphysis and diaphysis once the epiphyseal plate closes. So because of that, in bone lengthening ceases. There's no longer lengthening happen. And this is usually happen at the age of 18 in females, but it's been said that it will happen around like in males when they're turned into age 21. Lots of regulations happening during the bone growth process. The major ones would be the hormonal involvement. So the growth hormone play a most important role during the infancy and the childhood, stimulating the epiphyseal plate activity. So that's why you would see the kids grow faster during that time. And thyroid hormone, it modulates the activity of this growth hormone, ensuring some proper proportion. So if you would remember, there's a growth spurt happening during the times of puberty time. So thyroid hormone is active at that time. You would see kind of kids suddenly becoming like tall. So that is what is the influence with the thyroid hormone towards the growth hormone. On the other hand, our sex hormones plays a role as well. Testosterone in males and estrogens in females, and at the puberty, more it promotes the adolescent growth spurt. So, in addition to thyroid, puberty, the sex hormones play a role too. And the end of growth by inducing epiphyseal plate closure happens. Excess of or deficits of any hormones can cause abnormal skeletal growth. The next important topic would be the bone remodeling. So bone remodeling, it consists of both bone deposit and bone resorption. It occurs at the surface of the both periosteum and the endosteum. And we call them as remodeling units, which we consider them as packets of adjacent osteoblast and osteoclast, and they coordinate the remodeling process. With related to the bone deposit, the new bone matrix is deposited by osteoblast. And when you read the textbook, you would find a word called osteoid seam, which means like there are some bands of unmineralized bone matrix which marks the area of new matrix. And the calcification front would be between the abrupt transition area between the osteoid seam and the older mineralized bone. So you start with osteoid seam and you have the calcification front, and then you have the older mineralized bone. In the resorption process, it is a function of osteoclast, so bone formation by blast, bone resorption by osteoclast. They dig depressions on or grooves as they break down the matrix, and they secrete some lysosomal enzymes and proton ions, and that will digest the matrix and it will convert the calcium salts into much more soluble forms which can get absorbed into the blood. And also they perform some phagocytic functions which demineralize the phagocytic function in the demineralized matrix and the dead osteocytes. How they do is they digest these products and transcytose across the cell, and it released into the interstitial fluid or and then into the blood. And once this resorption is complete, osteoclasts, they can undergo their own cell death, which we called as the apoptosis. Of the osteoclast is happening with the involvement of the parathyroid hormone and the immune T cell protein. So that is important. Remodeling has to be controlled and it occurs continuously, but it is regulated with genetic factors and some two control loops. The first one would be under hormonal control. The second one would be in order to as a response to the mechanical stress. So with related to the hormone control, it's considered as a negative feedback loop, which controls the blood calcium levels. And of course, everybody would know that calcium is important for many cellular functions and the body functions: nerve transmission, muscle contraction, blood coagulation, as well as cell division. So 99% of calcium, you would find it in the bone and the rest would be in the blood. And people would know that intestinal absorption calcium requires vitamin D. With related to the hormonal control, parathyroid hormone produces which is produced by the parathyroid gland, um, and it is produced in response to the low blood calcium levels. So when it sends the low blood calcium levels, the parathyroid hormone secretes by the parathyroid gland, and it stimulates the osteoclasts because they destruct the bone and releases calcium from the bone. And osteoclasts get activated, it resolves the bone, and calcium is released into the blood, and that will raise the calcium levels. And once you have a particular level, the PTH secretion stops with the homeostasis balance, and the calcium levels falls back into the normal level. The other hormone involved with the calcitonin, which is produced by the parafollicular cells of the thyroid gland, and this is secreted in response to the high levels of blood calcium. So it's been said that the effect is negligible in the physiological state of the human beings, but it can be administered externally as a pharmacological effect when you have like high blood calcium levels in order to lower the calcium levels in the body. So in this figure, it shows what we have discussed with related to the parathyroid hormone. When you have low calcium levels, it will secrete this parathyroid glands. There's 4 glands behind the thyroid gland, and it leads to increased PTH, parathyroid hormone, and that leads to stimulate osteoclast that will increase the calcium back into its normal levels. The other hormonal controls involved some not popular but important hormones, the leptin, which is released by the adipose tissue, and it's regulate this process by inhibiting the osteoblast. And the serotonin is another important hormone which which is involved with the neurotransmitters, which is a neurotransmitter which regulates mood and sleep, but it's also interfere with the osteoblast activity, which leads to maintaining the calcium level. So serotonin is made in the gut and it's secreted into blood after a meal, and it may inhibit bone turnover after a meal. So bone calcium is locked in when new calcium is flooding into the bloodstream. The other main control mechanism would be the response to the mechanical stress. So bones reflect stresses they encounter. Bones are stressed when weight bears, when they do bear weight on them, or due to the muscle pulls on them. So according to the Wolff's law, what it states is that bones grow or remodel in response to the demands which is placed on them. So stress is usually off center, and when you put weight onto the bone, so bone tends to bend, and bending leads to compresses one side and stretch on the other side. And it has been said that because of this mechanism, the diaphysis is going to be thickest where bending stresses are greatest in the bone, and also the bone can be hollow because the compression and tension, they cancel each other out in the center of the bone. So center of the bone is where you have the lots of hollow, and it's okay to have a hollow in the center because that is not where that the weight is being transmitted too much onto it. So here what it's been shown here is showing the weight bearing line, and it's been created some tension which is going away from here at the center, and then the compression also coming into the center. So the tension away and the compression towards it cancel out the tension over here. So in these areas that you would find the hollow, but wherever the tension is goes, the bone tends to be bent, and those areas going to be much more hardened and stronger. So the Wolff's law also explains the handedness, which is the right or left-handedness, is thought to be a result in the thicker and stronger bone of the corresponding upper limb, and the more you use it, the more you put on to the stress, and that would be the how we decide the handedness. And the curved bones, it's been according to the Wolff's law, it says like they are the thickest, were most likely to buckle. The trabecular, the Wolff's law also explains the trabecular formation, because they form the trusses or struts along the line of the stress. And large bony projections occur where heavy active muscles going to be attached. And that's why, like the weightlifters, they have enormous thickenings at the muscle attachment sites in most muscles. And the bones of the fetus are on paper, their bones are very features because their bones do not get much stress on the bones if they're bedridden, or in the fetus you don't get much weight onto your bones. So how much, let's in here we'll talk about how much mechanical forces communicate with the cells responsible for remodeling. So it's been said that deforming a bone produces an electrical current in the bone. So since compressed and stretched regions, they are oppositely charged, and these electrical signals direct remodeling. That would lead to the remodeling process. And the compression or the tension, they changes the fluid flows within the canaliculi, and it's thought that would also stimulate the remodeling process. So all in all, the key feature that you need to remember is the hormonal controls. They determine whether and when the remodeling has to happen, and in response to the changing in the blood calcium levels, but the mechanical stress is the one which determines where this remodeling needs to happen. So after the remodeling process, you would need to know about some detail about the bone repair. So where you need to have a repair is when there is a fracture. So fracture is called as breaks. So during youth, most fractures can result from trauma because you're highly active. And in old age, it's most result from the weakness of the bone due to the bone thinning process. So fractures we can classify either or due to these reasons based on the position of the bone ends after the fracture, the completeness of the break, or whether the skin is penetrated. If the bone ends retain in normal position, we call them as non-displaced fractures. If the bone ends are out of the normal alignment, we call them as displaced fractures. Also, if the bone is broken all the way through, we call it as complete fractures. If the bone is not broken all the way through, we call them as incomplete fractures. And if the skin is penetrated by the bone ends, we call them as open or compound fractures. Or if the skin is not penetrated by the bone's ends, we call them as closed or simple fractures. So it can also, these fractures can also be described by the location of the fracture, its external appearance, and the nature of the break. So here it will show some fractures, the spiral fractures, the epiphyseal fractures, the compression fractures, which is happening in the vertebral body, as well as some comminuted fractures, so which means like a lot over here, and the depressed fracture in the skull, and the green stick fracture in the tibia. With related to the fractures, you need to know the fracture treatment and the repair process. So the treatment involves the reduction, the realignment, and realignment of the broken bone ends. So the reduction would be either closed reduction, where the physician can manipulate to correct position, or in the open reduction, you need some surgical procedures. It would keep in the secure, in a positioned by pins or wires, and it secures the ends. And of course, the immobilization is needed, and it's being done either by cast or retraction. And time needed to repair depends on the bone break, broken bone, or the age of the patient, because some bones they heal faster, some bones they do not heal faster. So in young kids, the bone healing is faster compared to the old age. And the repair mechanism, it involves four major stages: the hematoma formation, fibrocartilaginous callus formation, the bony callus formation, and then the bone remodeling process. When you have a fracture, the arteries or the blood supply to that area is being distorted, and from the torn blood vessels, the blood is seeping out. It forms a hematoma. And due to the release of the chemicals and the hematoma formation, the site is now swollen and painful and inflamed. Next, then the capillary starts to grow into the hematoma from the surrounding blood vessels. The phagocytic cells comes into the area and they clear cell debris. The fibroblast cells, they start to secrete collagen fibers to span, break, and connect the broken ends over here. And then the fibroblast, cartilage, and osteogenic cells begin the reconstruction of the bone, so creating cartilage matrix of the repair tissue, and then osteoblast starts to form spongy bone within the matrix. So this mass of repair tissue is called the fibrocartilaginous callus formation. Fibroblast involved, formation, or cartilage is involved. All these things, fibrocartilaginous callus formation. The bony callus starts to form within 1 week, where the new trabeculae appear in the fibrocartilaginous callus. The callus is then converted into bony or hard callus of the spongy bone, and then the bony callus formation continues for about 2 months until it provides a firm union between the broken ends. And the bone starts to remodel, begins during the bony callus formation, and it continues for several months. So excess material on the diaphysis, exterior, and within the medullary cavity is going to be removed. The compact bone is laid down to reconstruct the shaft wall. You would see the compact bone you would find at the periphery, and the final structure resembles the original structure, so responds to the same mechanical stresses. Once again, everything in one picture. Yeah. The next one would be the bone disorders. So imbalance between the bone deposit and bone resorption underlie nearly every disease which affects to our human skeleton. So there are 3 major bone diseases. This is not the only list, but let's talk about these ones in this lecture: the osteomalacia and the rickets, osteoporosis, and the Paget's disease. In osteomalacia, the bones are poorly mineralized. So osteoid is produced, but the problem is that the calcium salts are not adequately depositing in the osteoid. As a result, they would get like soft, weak bones. And the main symptom of these patients would be pain occurring upon bearing weight. Rickets and osteomalacia is commonly seen in adults. The rickets is the osteomalacia of children, and this results in bowed legs and other bone deformities because the bone's ends are enlarged and they're abnormally long. The causes for rickets would be vitamin D deficiency or insufficient dietary intake of calcium. The other common bone disease would be the osteoporosis. It's a group of diseases in which bone resorption exceeds the deposit. The matrix remain normal in osteoporosis, but the problem is the bone mass is going to decline. The spongy bone of the spine and the neck of the femur are the most susceptible, vulnerable places. So vertebral and hip fractures are common with osteoporosis. The risk factors would be aging, postmenopausal women. It affects 30% of women aged 60 to 70 years and 70% by age 80. It's commonly seen in Caucasians. 30% is Caucasian women will fracture bone because of this osteoporosis. And also estrogen play a role in bone density. So when the levels drop at the menopause, then women tend to be in higher risk. And men's, of course, they are less prone to protection by the effects of the testosterone because they do not go under like menopause kind of a thing. But if they get treatments, for instance, for androgen suppressing drugs, then they are much more prone to osteoporosis as well. In addition, petite body, insufficient exercise to stress bones, diet poor in calcium, protein, smoking, hormone related conditions, immobility, and as I mentioned before, males with prostate cancer, which takes androgen suppressing drugs, leads to development of osteoporosis. So the treatments would be traditional ones: calcium, vitamin D supplements, weight-bearing exercises, hormonal replacement therapy, and HRT is slowing down the loss, but it does not reverse it. So you can slow down the process. And HRT is associated with some risk with related to heart diseases. The other drugs for osteoporosis would be the biphosphonate, bisphosphonate. It decreases the osteoclast activity and it's partially reverse the osteoporosis in the spine. And also selective estrogen receptor modulators, and that will really prevent the targeting breast and uterus cancers. And the denosumab, which is the monoclonal antibody shown to reduce fractures in the men with prostate cancer. And preventing would be the plenty of taking calcium in diet in early adulthood, reduce consumption of carbonated beverages and alcohol, plenty of weight-bearing exercises. The Paget's disease is seen like excessive and haphazard bone deposit and resorption. And it's almost like sometimes detected accidentally when you go to take some x-rays and so on. It's called the Pagetic bone disease, and the very high ratio of spongy to compact bone, and what you would see is reduced mineralization of your bone, and usually occurs in the spine, pelvis, femur, and the skull. This rarely occurs before the age of 40, so it's commonly seen in old age. The cause for this Paget disease is unknown, but people would think that it's possibly due to viral. The treatment includes the calcitonin and bisphosphonates. With related to the bone development, the embryonic skeleton ossifies predictable. So fetal age is easily determined from X-rays or sonograms. Most long bones begin ossifying by 8 weeks with their primary ossification centers, and all of them have been developed by the week 12. Then at birth, most long bones ossified except the epiphysis. The epiphyseal plates, they persist throughout the childhood and adolescence, and at the age 25, all bones, they start to complete ossified and skeletal growth starts to cease. And you would see here the fetal primary ossification centers at the 12th week. It's not like seeing properly the ossification centers, but you would see most of the skeleton have been formed in this. And with related to the age-related changes in the bone, in children and adults, adolescence, the bone formation exceeds the resorption. So males also tend to have a greater mass than females, so gender play a role as well. But in young adults, both is going to be balanced. Bone formation and the resorption is a balanced process. And in young adults, but in adults, bone resorption is exceeding the formation. So you have to be careful, have to keep your diet including more calcium and so on. The bone density, they change over lifetime and largely determined by the genetics and genes for vitamin D. Cellular docking determines mass early in life and osteoporosis risk at the old age. The bone mass, mineralization and healing ability decrease with the age beginning in the fourth decade. So you don't find this decaying or demineralization in the bones of the skull, which is good. So it protects the brain area. The bone loss is greater in the Caucasians and in females. So this is the end of the chapter 6, and I will see you in the next lecture.